Hi, good afternoon, everyone, and welcome to our final ECHO session for the year. So we are a small crowd today, but that's fine. We're just going to have a little bit of a brief overview of what we've done for the year so far, and get some ideas as to how we can proceed, what we've done well, what maybe we need to improve on a little bit, and get some suggestions and comments as to how we can improve. So I'm going to start the slideshow as soon as I figure out how to do this. I think my brain stayed home today. Oh dear, I've completely forgotten to do this. Here we go, right. Completely forgotten how to do this. All right. So this is going to be our 2021 brief review. Obviously, we can't go into a comprehensive review, I think, today. It will consume more than what we have. So again, we just want to thank University of New Mexico as well as University of Washington ITech, both of whom were instrumental and fundamental in the second program. And as usual, I have no disclosures to talk about. So when I was preparing this conversation, I stumbled across this picture in actually one of the Google Keep documents, and this was very early to the beginning of ECHO, and it kind of threw back some memories. I don't think I even own this shirt anymore, and Sharon was there giving lots of support. So 2021 has been really interesting, I think, for all of us. It's our second, I would say, full year of COVID-19, and we've sort of gotten it under our skin now, with the vaccine rollouts. We had lots of conversations about that, and all our hopes and prayers what the vaccine rollout would have accomplished, and coming around to the end of the year now, we can kind of look back and see, well, how well did our expectations meet reality. And again, at the beginning of the year, we won't talk as much about the variants, and now we're up to Omicron variant, and the vaccine is going to work, and the antibody treatment is going to work. What does this mean in terms of our numbers? And we have our fourth wave now of COVID-19. It seems one of our worst waves of all. We're seeing close to record amounts of new cases, close to record amounts of new deaths. We're averaging 1 an hour now, which is really traumatic for all of us. And we've endured lockdowns, we've endured states of emergency. And through all of it, I think, both as individuals in our private lives and as caregivers and persons who are involved in the HIV care delivery, we've sort of gotten accustomed to this almost cliche term, this new normal. Whether it's in our own private lives, and as well how we deliver care to persons with HIV. And it's an ongoing learning process. Several members of our staff had to go to quarantine. I think one of our staff members right now is at home having been diagnosed with COVID, and it's coming closer and closer to home. Even though we're rounding onto our second year, 2 years into COVID-19, that we'll still be talking about this extent of intrusion into our lives. And this beginning of our third year of Mrftt HIV STIF, we've kind of take all of this under our skin, and we're trying to still make sure that throughout all of this and throughout all our collective engagement and collective trauma, that we still have to make sure that we remain relevant, that we have to keep up with everything that we're learning, both in terms of how HIV care is changing, how HIV treatment modalities are changing, especially with that in COVID-19. And one of the consistent issues that we've been having is, how do we stay relevant and stay engaged in terms of finding new cases and new interesting cases and new learning experiences, so that we don't find ourselves redundant and find ourselves not saying the same sorts of things over and over. So I just want to run through what we've done in terms of the didactic portion of our ECHO series for this year. So the first two, coming out to the start of the epistle this year were COVID-19 cases. When we were talking about what we knew about it at the time, as well as a session from Dr. Behrens, who came on board this year, And really, we have to thank him tremendously for his experience and for his input, because he also assisted with the Jamaica Echo, and he's a very busy person, and he still was able to find some time for us. I was talking about COVID-19 and vaccinations, and it would have given several talks, and every time he gave a talk, even though it was just a couple of months later, so much had changed, right? Then we spoke about partner notification, STIs, and I think this was Dr. Edwards, who is leading the STI portion of the ECHO series. And it was really interesting, I think, that even though some of us have been involved in HIV care for decades, that there's still this issue of partner notification, how we do it properly, how we do it well, how we engage our patients in terms of this complex issue, and all the challenges that get folded in terms of that. We had also begun having regular mental health and psychosocial sessions, and Belinda, who is on maternity leave, and a brand new bouncing baby boy, and we wish her all the best as well, started sessions on psychotherapy, and Dr. Tobago given a session on HIV and aging, and I think we're learning more and more about how HIV intersects aging, because we now pretty much know that someone living with HIV who takes their medications is going to live into old age, but we still don't have a clear grasp on what that means, what aging with HIV means. And I think one of the presentations I would have given was, I think in previous series, was HIV and comorbidities, and how we are still seeing that person living with HIV develop comorbidities 10 years ahead of our HIV-negative counterparts. What does that mean in terms of the next 10 years, 20 years, and how we manage person living with HIV? I mean, one of the patients I saw in the clinic this morning was a 23-year-old young man who just diagnosed 2 weeks ago. And we're having that conversation about he's going to be fine, he's going to live into his 70s. He should not fear an HIV diagnosis. But in the back of our mind when we're having this conversation is also how much we don't yet know about what HIV is going to look like for this 23-year-old man on currently available medications. We're talking about comorbidities and weight gain and everything else. Again, COVID-19 came up. I think, again, this is another session with Dr. Behrens. And one of the things that we're going to try to do more of, and I'll talk about this more at the end of the presentation, we had a special invited session by the Children's Authority, because that's another issue that we still come into contact with on a regular basis, when we have 17-year-olds and 16-year-olds coming into us for post-exposure prophylaxis, or who used to be diagnosed living with HIV. How do we deal with the issues around consent and how HIV and the law intersect with each other in persons who are below the legal age of consent, which is 18 in Trinidad and Tobago, and how we ensure we are both following the law as well as giving the best care to our patients. So these next seven sessions were again on COVID-19, and another issue that we see fairly frequently, especially now we have both men's and women's clinics, that we are picking up more STIs. And we, there was, I think, a couple instances where patients were referred to us and we realized that the STI management was not probably well done. So we wanted to make sure we brought everyone up to speed in terms of how we manage common STIs. Again, we had a psychosocial session by Ms. White on personality disorders. And this is one of the things that I found really interesting, because as part of our psychosocial protocol, we spoke about trauma-informed care and how we approach the so-called difficult patient, because we have these patients that we see that we always have so much difficulty breaking through to them, and they are difficult personalities, they're hostile, or they just don't seem to be able to internalize messaging around adherence and treatment. And that particular presentation, I think, and the subsequent one, which was the follow-up session, really opened my eyes as to how to assess that quote-unquote difficult person who's not well adhered to treatment. Are we dealing with one of those personality spectrum disorders? TB screening guidelines. TB is a major comorbidity in persons with HIV around the world, and in Trinidad as well. And the WHO had put out had updated their TB screening guidelines as part of their most recent update. And, as given that part of my responsibility is seeing TB HIV cases in Cora, I thought this was an opportune moment to update everyone about how these guidelines were modified, because I think we're still a little bit behind in terms of where we need to be in terms of how we screen up our newly diagnosed cases, and not just newly diagnosed, all the patients who are currently in care, in terms of the systematic screening for TB in persons living with HIV. Next session was disclosure, and again, this is one of those issues, no matter how long we've been in HIV care, that we always have to intersect with on a regular basis. The person with HIV who is not virally suppressed, who has a new partner or a partner who've had for a long time, who just can't get around to that point of disclosure. How do we, manage beneficial disclosure? I think this was Dr. Khan, who came and gave a wonderful conversation. She's always excellent. She's always so engaging. How do we get our patients move towards this so-called beneficial disclosure? How do we get into that point? Because we still have to think about, as part of our mandate, prevention of transmission from persons with HIV to their partners, and how do we navigate all these complicated issues around intimate partner violence and the real concerns about, how safe is it for this person, usually a female, to disclose to their partner who has told them point blank, if you ever infect with HIV, I'll shoot you. And these are real things, right? And after that, we spoke about the updated WHO guidelines. That was a conversation I had, and how it had changed in so many ways. I think we had to sort of boil it down to some of the most salient points, because the guidelines keep changing so much every few years. And then we went on to syphilis and pregnancy. Remember, when we talk about the elimination of the child's transmission, right now I think WHO is talking about 3 different things: both HIV, syphilis, and also hepatitis B is one of the other issues that is coming up, and how we screen mothers for that. So we spoke about the syphilis part of that elimination conversation. This was another excellent conversation by Dr. Edwards. Remember, all these didactics are on our YouTube channel for anyone who wants to go over them, who thinks they may have missed one of these. They are still there. And again, the next, we're coming on to the second part of the year now. We spoke about personality disorders again. That was Belinda's conversation. An update on the vaccines and variants, talking about, well, at this point in the year, I think Delta was upon us, and we were thinking about these conversations about, are our vaccines going to still work? How do we think about COVID-19 vaccination in the future in persons with HIV? Are we going to be thinking about COVID-19 vaccination the same way we think about flu vaccines, right? Because as you get different strains of influenza every year, are we going to talk about different strains of COVID every year and having to update our vaccines accordingly? We're already talking about additional primary doses, or, well, the WHO doesn't want us to use the B with the booster dose. But right now we're at this stage, we're talking about second and third doses. And I think the Europeans are talking about fourth doses, especially with Omicron upon us, that we may have to consider multiple doses of vaccination to really blunt this new wave of COVID-19. One of the presentations Dr. Behrens gave, this is the management of treatment failure in the absence of resistance. Yes, again, a fascinating conversation. Remember, we presented this NADIA study, which was done in sub-Saharan Africa, which essentially told us, which is comparing dolutegravir to darunavir, that essentially, regardless of the activity of the nucleoside backbone, whether you have a lot of expected activity or not much at all, that once you have a potent anchor drug, whether it's darunavir or dolutegravir, that we can essentially confidently switch someone who's failing a first-line regimen to a regimen consisting of tenofovir, emtricitabine, or lamivudine, and that third drug. And it might have extension to any nucleoside combination and any boosted protease inhibitor or integrase or second generation integrase, so dolutegravir or bictegravir, and still expect high levels of viral suppression. And that, I think, is a real game changer, because one of the things that we used to think about and talk about and is still sort of bandied about as law in HIV treatment is that you must have 2 fully active agents. And there are persons right now, I remember, who were on 4 and 5 drugs because their nucleoside backbone was so compromised and they didn't have a lot of active drugs. We might be able to put almost all of our persons on first, second, and third line therapy on a single drug, right? With tenofovir, lamivudine, dolutegravir, and expect them all to suppress once they have no integrase resistance or no suggestion of the possibility of integrase resistance. And I think that's sort of coming around full circle from where we were at the beginning of the pandemic to where we are now, that we can circle back from 2 and 3 and 4 and 5 drugs and mega heart and double boosting protease inhibitors, all the way back down to all it is one tablet with active drugs. So this is not so much about how many drugs you're on, but what drugs you're on. Because it also used to be that you had to be on 3 drugs. That's it. Now there's 2 drugs combinations available. Whereas the lamivudine, dolutegravir, there's also rilpivirine, dolutegravir, and now cabotegravir, rilpivirine. That is teaching us more about, as I said, it's not about how many, but how potent, right? And so we were talking about what's new in HIV prevention as well, because that is also changing. The WHO is speaking about combination prevention now, whether it's patient education about safer sex practices, condoms, the rilpivirine vaginal ring. Now we're branching off, we're talking even about long-acting PrEP, whether it's cabotegravir, which is actually, I think, if on its way to FDA approval, not FDA approval, sorry, WHO approval, because that's I think these studies are quite, I think, robust, that cabotegravir is, long-acting cabotegravir is a good prevention option. The question is, will it get to the parts of the world where it's needed the most? Then we spoke about trichomoniasis. We had a really interesting case that's still ongoing. There may be a third update. This is actually a woman who is not HIV positive, who has had recurrent persistent trichomoniasis, who failed courses of metronidazole, secindazole. I think we actually built oral, intravenous, topical, and what actually what seems to be working for her is one of the treatments that is not so often referenced is actually boric acid, right? And it seems to be doing the trick so far. So that was really, because I'd never seen a case of multiple drug resistant trichomoniasis, and I'd never heard of this particular treatment, but it seems to be working. And again, coming on to the end of the year, again, recently we spoke about, again, another COVID update on vaccinations and treatments, because we are still, learning more and more and more. And the more we learn, the more we have to change how we approach speaking to our patients about COVID-19 vaccination. Because I think right now in Trinidad, we're still sub 50% in terms of vaccinations. It's starting to slow down. The willing have gotten vaccinations, and now it's sort of it's a battle of the Somme right now. It's incremental, case by case, person by person. I mean, fortunately, most of the patients I see in clinic on a regular basis are fully vaccinated, but there are still, I would say at least 2 or 3 cases a day who are in that state where they're still thinking about it, right? They still haven't quite made up their minds. And I think a lot of that is, and I think that this is one of the things that was discussed, there was so much misinformation, there was so much noise, there is so much fear that's being generated, that persons out there, they understand the importance of getting vaccinated, especially as persons living with HIV. They want to move to that vaccination point, but they're hearing about, and it even happened in Trinidad. I was really quite annoyed that, persons with responsibility are talking about, we still don't know if we take the vaccine if you're alive in 3 years. So I was like, really, no, man. Where is your data? Where is what is that being based on? So we still have to fight that uphill battle and educate person by person, case by case sometimes. And sometimes it takes a long time, and sometimes it's exhausting. But I think given what we're trying to save people from, it is an important conversation that we must have. And the last, coming down to the end, the last three topics. So we spoke about HIV Cure and the HIV Cure agenda. And again, it wasn't a comprehensive conversation because there is so much work and so much new stuff coming around in terms of approaches to HIV Cure. We just touched very briefly on broad neutralizing antibodies and where that seems to be taking us in terms of attaining a functional cure. We also spoke about some of those, that long list of drugs that affect what we call the sterilizing cure, kick and cure, in terms of where we are in terms of whether it's the histone deacylate drugs or drugs like disulfiram. How do we reverse latency? This final barrier. As a matter of fact, that same 23-year-old I was speaking to this morning asked me about that, about HIV cure. Why is there not a cure yet 40 years into the pandemic? I started drugs 2 weeks ago. Am I going to have to be on drugs for the next 50 years? So I mean, it was a really interesting conversation that we had. But that's on the mind of, I think, of every young person starting treatment nowadays. Am I really going to have to be on drugs for the rest of my life? And the last two sessions were another STI session. Again, we are still seeing high rates of syphilis in men who have sex with men. Dr. Edwards, we did a study out of this very center. I think the rate was north of 40%. So we still have that ongoing battle to talk about. And the most recent session that, again, was done last week by Dr. Behrens was a World AIDS Day special, talking about 40 years of the pandemic. And it was a really, a nostalgic conversation because a lot of the things he spoke about, I have, memory of, AZT monotherapy, not necessarily as part of treatment, because that would have been before my involvement with HIV Cure, but, the 076 protocol and AZT monotherapy in pregnant women and reducing the risk of perinatal transmission and conversations we would have had with the late Professor Bartholomew, God rest his soul, about those times, early on in before treatment was available, when we would give AZT monotherapy to the mothers, the children come out negative, but the mothers would die of AIDS because we did not yet have combination antiretroviral treatment, and how far we've come from those days, So it was really interesting to see how far we've come along in 40 years of pandemic, and next year will be 20 years of the government treatment program in Trinidad and Tobago, whereby treatment is available free of charge to all persons living with HIV. And, casting our mind forward to the next, not even 40 years, next 20 years of treatment, what is it going to look like in Trinidad and Tobago? What is treatment access going to look like? Are we going to solve some of those more difficult treatment issues with respect to how do we get more persons tested? How do we get more persons involved in care? How do we manage persons who are not virally suppressed? What are these drugs even going to look like in 5 years, 10 years? And so it all had 23 topics, which was, a good year's work. And, I spoke about some of my take-home points while I was giving this conversation. So I wondered if, I just want to open it up to anyone. What were your take-home points? What stuck in your mind in terms of some of the didactics we spoke about, and what captured your interest in the year that was? So I'll just pause here now, just for 5 minutes. I will speak about the cases later on. That's going to be a little bit shorter. So I open up the floor to anybody to talk about anything that's stuck in their mind.
Hi, Dr. Boyce. I know it was one of our more recent sessions, but it was really the conversations we had on HIV cure, advances and obstacles. Just to recognize that even though we had come so far, that we were still stuck in this place as towards how we go about actually still treating HIV. And I think that just really resonated with me, that for so many persons, we're now having this added layer of, I don't want to use the word trauma, but this other layer of fear as PLHIV is now dealing with HIV as well as now living with HIV in a time of COVID. So that was just one of the things that really stuck with me from all of these sessions.
All right, that's really important because the whole I think need for cure comes from the fact that in a lot in some parts of the world, HIV treatment access is not guaranteed. Right, there is a paywall, there is a barrier. I mean, whether it's financial or it's geographic, that you live 2 or 3 days away from treatment, and how do you get there, and what COVID-19 has meant for the sustainability of the HIV response. So that was really, I think, really important as well. Yeah.
I think the other thing that COVID-19 has brought to us is the misunderstanding as to how fast the vaccines came in. And because of that, a number of our patients ask if the vaccine against COVID-19 could be generated or manufactured so quickly, then how come there's no cure for HIV yet?
Yeah.
So this is a topic that comes every so often. And then the one other thing that we meet, or I meet, is the fear amongst some of our HIV-infected patients who are so scared because of COVID-19 that they stay indoors even when they don't have their medications. And it takes them really, really a lot of courage to come out and come to the clinic and they get their medications. Then just veering into our last session with Dr. Behrens, this might reveal my age, but it reminded me quite a bit of the really, really good old days when you sat across the table with the patient, a fellow human being, and you told them that they were HIV positive, and then the best you could do is look away because you had nothing more to tell them. And then the most terrible time when you told people that they're HIV positive, the medicine is available, but they're so expensive, they could not afford them. And it reminded me of a very beautiful scenario which will be in my mind forever. Just before I came to Trinidad and Tobago, we, as some young doctors, started an HIV clinic at our referral hospital, and people thought we were mad because there was no medicine. But we talked to these people, and a few of them who could be able to afford medications bought. And within 1 or so years after we started the clinic, the government started treatment. And then I came to Trinidad. And when I went back to the treatment site, there was hardly anybody on a wheelchair or a stretcher. Everybody was walking and they were strong and energetic. And it's beautiful, really, that we are coming now to a point where those who are almost giving up because of many pill burden can now be safely be put back on one pill. Actually, I told one lady today that when she comes back, she might get one pill once a day. And she told me, Doc, you put a big, big smile in my face. And she was really beaming. So it's those who have been there with HIV and AIDS, it's been a rough walk, but the end of it has been extremely fruitful. And then all of us, I'm sure, are in touch with relatives, friends, and patients who do not want to be vaccinated. Like Dr. Boyce said, they're waiting. When you ask them what they're waiting for, the answer is that they're waiting. And some of them are very close relatives. I have close relatives here who don't want to be vaccinated. I have friends who don't want to be vaccinated. And I come across patients who still don't want to be vaccinated. Like Dr. Boyce said again, we just need to talk and keep talking because people are actually dying. But overall, the sessions have been very, very informative. And I think the more we continue, the more we get informed and the better for us and the people we look after.
Okay, so let's move to the cases part. So there were 16 cases in all, and I went through essentially all the cases that and it was a really wide range of demographics. So the first case was a 35-year-old perinatally infected young woman presented with a rash, and that we presented her later in the year because she experienced virologic failure. There was a 23-year-old hepatitis hepatitis B, HIV infected bisexual male, there was a 61-year-old, heterosexual female, and so all over the map. And they all had different clinical problems, all had different risk factors, and we all came up with different solutions. And it was really interesting how organically some of those solutions came about for cases that, because every now and again you sort of go online and you go to, let's say, Clinical Care Options has a webinar on management of the complex patient, realizing, oh, they have nothing on us, because it's the same set of problems no matter where you go. And the difference is that sometimes we have to operate with a slightly reduced toolbox, and we have to make as much use of that toolbox as possible. But some of the common themes over the cases were the impact of COVID-19 on the ability of patients to access care, as Dr. Musa just mentioned. There's some patients who, due to COVID-19, are afraid to leave their houses. There are patients who, because of COVID-19, lost their jobs and don't have the ability to even, get $10 to come to clinic and go back home. They have no food to take their medications. And I see Abigail is here. We have had so many conversations about, all the pain other patients are going through and how badly COVID-19 has disrupted their ability to even think about treatment as a priority, because they have so many other, competing things. Their rent is due, they have no idea how they're going to pay it. The bills are due, they're switching off the lights. They live in a little shack and scavenging, trying to get enough to get food for not even themselves, but sometimes their children. And COVID-19 has really been a terrible disruptor for in the lives of our patients, and really did contribute this year in measurable ways to our patients' ability to suppress and remain on treatment. Again, another common theme was the importance of psychosocial support, whether it's, family, friends, state support in some cases, the limited ability that we have to support the lives and livelihoods of our patients, how critical it is to have, some, ability to buffet against, what, COVID-19 in general, as well as just living in general, does the person with HIV. The impact of stigma, discriminations, and patients' willingness to seek care. That, was a theme I saw multiple times, that in patients who fall out of care, whether it's internalized stigma or just stigma, from external persons or external agencies, that, that was one of the issues that really required, a lot of, time and patience in addressing, because, there's one of the patients I remember who the cases we presented, his partner had died, and was sort of the talk of the town that the partner died from an AIDS-related complication. So everyone naturally assumed he was living with HIV and, with abusing him, walking on the street, telling him dead from AIDS. And it's every day, someone has to walk through that wall of abuse to come to clinic. And some days he just chose, like, I can't put up with that today. And one of the other important themes that came through is the importance of differentiating models of care, that we have to be able to adapt and to be flexible and to be imaginative in how we think about delivering HIV care to the persons who are our responsibility to deliver that care. The model that we used to use, that very centralized medical model, Monday to Friday 8 to 4, is out the window many years now. And but the challenge is, how do we continue to adapt? So we've implemented some programs. But having implemented those programs, what new needs are we seeing? What new approaches do we need to implement to continue to get our patients in care and to save lives? Because that's really what the end point and the end all of all of this is. How do we save lives? How do we ensure that HIV doesn't claim another soul in Trinidad and Tobago? So looking forward, and this is again another picture I found. I have to give thanks to Conrad for his excellent camera work. This was very early on. The shelves are bare. I know they're full of books and boxes. But looking forward to 2022, I think one of the things we have to pay attention to is, the continued emphasis for community engagement and emphasis on eco model of learning. Essentially, how do we engage our learners? And again, I thank everyone who's here today, later on in the year. How do we continue to engage our community of practice? One, for ideas, for input, and how do we continue to make sure that we remain relevant to your needs moving forward? How do we, get encourage and excite our learning community to participate, whether it's, presenting didactics, presenting cases, giving us ideas as to what you guys want to hear, and how do we think about expanding the number of presenters we have? We got Dr. Khan to present. We got some special invited presentation from the Children's Authority. Dr. Barnes has come on board as well to assist. We need to think about broadening our net in terms of who can come in and really give our learners a new perspective and give us a new perspective on different aspects of HIV care. So in terms of our final question for the community, how do you guys want us to evolve? How do we need to improve, or can we improve our care program? And the final question is, what was memorable for you for this year? Not just when it comes to HIV and ECHO and your role as providers. Was there anything that you want to bring up or would like to talk about that was memorable for you for 2021? And I will leave that question hanging. And that is the end of my presentation. Again, thanks everyone for your participation. And I'll leave those two questions open for anyone who would like to contribute. So that's one thing that was memorable for me, was convincing my parents to get vaccinated. Because they used me as a guinea pig, that was really, really interesting, because when vaccine was coming, my dad was hesitant. My mom was willing, but kind of didn't want to poke that very much. So I think when the first batch of COVID-19 vaccines came out, and it was AstraZeneca at the time. Yeah. And and at this point in time, there was still a lot of turbulence in the news reporting cycle, shall we say, about these cases of clots coming about, and I was like, oh Lord, what is this? So went ahead, dug it up and said, listen, it's a 6 in a million risk, I'll do it. Fine. Because my dad's in his 70s, mom's in her 70s. Yeah. Dad has comorbidities, sister has comorbidities. I'm a healthcare worker. Yeah. I am at risk of bringing something nasty home. Yes. So it's like, I'll take that risk. And that was some of the conversation I was having with my patients as well. Because when they asked me if I'm vaccinated, I said yes, and this is why. Because it's not just about me. It's also about the people we care about, and in that wider penumbra around us, that's the people that we want to make sure we protect from COVID-19. So I think after I got vaccinated, thankfully I didn't have very much in the way of side effects. Yeah. But I realized my dad was kind of watching me for a couple of weeks. I was like, "You're good? Yeah, I'm fine. I was like, okay, fine. So once I survived the initial post-vaccination period, everybody got vaccinated, and that was so that kind of made me chuckle a little bit. I was a family guinea pig, but that was fine.
I think one interesting thing which is memorable for me this year is when I sat down at home and started thinking about the last time I was out of my house after 8 or so p.m. and I couldn't remember. And, and it didn't bother me at all. But the other memorable thing is how we have managed to treat our patients who are failing first line without any resistant tests done. And I think we've managed to do well. But I think the worst memory I have is when we reached a point when patients came in and either the atazanavir is gray, or it is blue, or it is 2 capsules, or it's 3, or there is none. And all these instances, patients think you're giving them different medications. And then when we had to juggle between atazanavir and Calitra and then darunavir to Icentrest, I sincerely didn't think that would happen, but it has come and it has passed.
And we're in the middle of a rat cycle, we're stuck up. So,
And now I'm told the government is not buying raltegravir at all, and which I keep telling Dr. Boyce every time I meet him, that he needs to talk to whoever they are, because there are certain patients who need that raltegravir in combination with other medications that are not in dolutegravir, 3PC, and tenofovir, especially those who have got kidney problems. You're not going to give them dolutegravir and tenofovir 300 milligrams because the kidneys will just get worse. And you're not going to give them any other medications because they're resistant to them. So we still need Icentress.
I just want one quick anecdote. When you speak about, managing to keep our patients suppressed, Sharon Soil-Abbasi, which is one of our senior nurses, brought up a case because she was so excited about this case. This person has been in care for 13 years and never suppressed. Wow. Never suppressed in 13 years. And they do that individual pill buying.
Yes.
Case because she's an elderly woman, but middle about 60s, right? She has some cognitive impairment issues, but she's able to manage simple tasks. So they did that whole thing where they put little pill bags and put a daily dose of medication, so a once daily regimen. I think Chuba that is an on and worked with her, and for the first 13 years, undetectable viral load. And she was like, yes, middle of COVID, middle of the pandemic, all these different challenges. I think we were so happy that, despite everything, after 13 years, we still finally. And I think that was one of the big lessons that never give up. Never give up, never give up, never give up. And she did really well.
I would share that with one of the patients I presented, a mother-to-child transmission case, who was on about 11 pills a day and had diarrhea, was vomiting viral loads in 200,000 copies. And at one point, she talked to me like she was just giving up. But when we presented her, we all agreed that we could switch her to Biktarvy. And 29 days of starting Biktarvy, the viral load was down from 250,000 to 57. When I saw the report, I literally ran across Mrftt sending her messages. Can I call you? Can I send you a copy of this? Where you? Can I talk to you? And Biktarvy really is, yes, that's another memorable thing for this year. It's done wonders to some of our patients, and thanks to God, soon we'll get dolutegravir, and a number of our patients, I believe, will make us smile more. It's a lot to be happy about, and a lot to hope for. So now, what way forward? Maybe, like you suggested, maybe invite a few, or just inviting a few more guest speakers on topical issues. Someone just crossed my mind, somebody like Dr. Don Martins, would you be willing to come and talk? Yeah, because he's an infectious disease specialist. He's looking after HIV and AIDS patients. So
he's been on my mind for a long time, but I think when COVID-19 hit, and remember he was chief of staff.
Yeah, he was in Cuba all the time.
I could only imagine the kind of pressure that he was in.
Yes, agreed.
I mean, he's invited all the sessions, but I think he came like the first one or two.
Okay.
But I don't think he because he's a clinician. 2 p.m. on a Thursday is difficult because that's either just after war runs or he's still rounding. So that's tricky. Because a lot of other treatments I saw, I think all of them, other than Tobago, hospital days. Right. So 2 p.m. is still middle around for most of them. So, but that's been. Especially when it came to COVID-19, I would have really loved to hear his experiences. But again, I don't know much he can share because he would have been under embargo in terms of what information he released.
I don't know whether that's a question from Omari.
Yeah, it is. So it's from Omari. Yeah. Do we think they will start buying Cabenuva? So
how much is it?
$4,400 US a month. So I somehow doubt it, unless we get a special reduction because we're a
rich country.
Through the medicines patent pool. I did. That's the only way we get access to it. Because there are some patients who need it. There are some patients who, for example, we have a couple of patients with cognitive impairment. Most of them, interestingly, most of them are men. But they can't do once a day medication. They can't. The only problem is that most of the persons who would be failing or would experience treatment failure on a first-line regimen would have most likely failed while they were on efavirenz and would have developed treatment resistance that would affect one of the drugs in carbamazepine called rilpivirine, a drug in the same class. So it limits for most of the patients who need the most whether they can access it.
Agreed.
Because they already have non-nucleoside resistance on it. Yeah. So that's the difficulty. That's the difficulty.
And then even if somebody was to give us a better price, that also depends on the quantity you're buying.
Yeah,
and I don't think the country would be in a position to buy so much.
Because right now I think the way it's positioned is either positioned as switch therapy from someone who's already viral suppressed. I don't have it as initial therapy. I think mostly said we're going to switch therapy, if I have to remember correctly. But either way, even if they reduce it significantly, I think TLD is single digits US. It can't get less than that. So the only mechanism by which I see this happening is with as an ad hoc purchase for small numbers of patients.
Yeah.
In which case, it's not going to be worth the company who is bringing it in while. To treat 10 patients or 20 or 100.
Have they decided whether you can just go straight to the injection or they still stuck on
I think
oral medication?
Right.
Because there's a report that really you don't need a leading oral dope medications before you give the injections.
So I think based on the safety profile of the drug, that's what they would say.
Okay.
That you want to appear to have significant toxicity from even the oral lead anyway.
Yes.
So I mean, I don't know if that is as yet fully approved. I think that's partly the evidence that there may not be a need for it. Okay. Any other comments or questions or concerns or suggestions?
Maybe just jokingly say that it took us, is it 3 or 4 years to bring in dolutegravir? So,
yes.
So to bring the cabo and rilpivirine might take even longer.
Yeah, because we have to build a case and we can think about individual cases who need it.
Yeah.
All right. So I think on that note, we'll wrap up. It's been a very interesting year. And again, I just want to thank everyone who has been supporting our channel, quote unquote, Mrftt HIV STI Echo. We will be resuming in early January. Look out for the email, watch this space. And again, if you would like to get in contact with us, you can. And give us any suggestions, we really welcome your input. And we will start off 2022 with a bang, hopefully. And so remember today that would be in our group that I think Howard starts at 3, this session for the Caribbean Community of Practice Area. They're all behind, so if you want to take that into, you can. And I think that's it for us today. So thank you, everyone. 5 minutes.
Also, we also have that men's health session that's going to be taking place later on tonight at 7 p.m.
Yes, so that is for men living with HIV. So if anyone who is listening knows when they can refer, you can just forward the invitation to them. That's also in a WhatsApp chat. So today's session is on grief and loss, and it was really interesting. I was speaking to a patient just yesterday. This is one of our in the men's clinic. He's, I think, in his late 40s. his mother died, a month ago, literally a month ago. So I invited him to the session just to talk about that because he's still processing. Because his mother died fairly suddenly. I think she got a series of strokes and then died from a cardiac event suddenly in the middle of a pandemic. So on top of everything he's going through. Yeah, so
I don't know whether it's just whether it's a coincidence or what, but of late it's like I meet quite a few people who have lost a parent and a sibling and an aunt, and it's quite common.
Yeah, I think it's going to be interesting. The data is going to tell us, but I think we don't fully understand the full impact of COVID-19 that has nothing to do with the virus itself, right? In terms of higher levels of stress, higher levels of anxiety and depression, and how those things affect cardiovascular disease outcome.
Yeah, because I was talking to a young lady yesterday. She's 24. She's a mother of one kid who is 2 years old. But her principal complaint is that just being indoors all the time is just unbearable. And little kids tell you this COVID is the worst thing because they can't come out. So you can, like, again, back to you can imagine an adult who has lost a job. You can't visit anybody. You have no means of putting food on your table. It's a very stressful situation that people are going through. The priest in church told us recently that somebody walked in the church compound and said, I just want to wash my head. I just want to wash my head. Those children and whatever are making noise and they don't have food to eat. I just want to wash my head. Just some cold water to clean my head. And it is, it's a piece of something.
I think history is going to record this very interesting. I think we are going to learn a lot looking backwards on what kind of civilization we are building based on what happened during this pandemic. Because so many of our most vulnerable persons are falling through the cracks. I think it's exposing a lot of weaknesses. The same weaknesses that HIV exposed in terms of how we treat each other, how fragile our, not necessarily our societies are, but how quickly they can degenerate into chaos and every man for himself and Lord of the Flies or something. And I think it also historically also look back on in terms of the information economy and how it's changed so much that it used to be that the doctor and nurse is so okay. Now, want to try to kill them? I mean, I heard someone on the radio. They were talking about a caller called in to say that one of their relatives in the US refused to take the vaccine because it was marked to be something. They subsequently got COVID, died from COVID. Their two sons says the reason she died was to sacrifice in ICU because she didn't take the vaccine. And I was like, wow. I don't think we fully understand how deep some of this runs and how, as healthcare providers, we need to be mindful of not even in a way that we can do something about it, but when you hear somebody that is like, what?
But
how to almost deprogram
the anti-vaxxers, some of the anti-vaxxers within this community will tell you that all this data the Ministry of Health provides are false. Nobody's dying from COVID.
Yes. Good.
And they would challenge you and tell you, but they're not even doing any autopsy. So how do they know? And in Kenya, where I was born, kids in high school in particular go to boarding schools.
Mm-hmm.
I have no idea what the relationship, but again, borrowing from what you're saying. But of late, there's been quite a bit of these children just burning school dormitories. They just burn them. There's one very good school which now is closed indefinitely because they burnt a dormitory. They were sent home. They came back. They burnt another one. They were sent home. They came back. They were burning another one.
Sure.
Yeah. And this is in different places. You hear of a school dormitory burnt in San Fernando, in Tobago, in Port of Spain, in Toco, in Santa Cruz. These things never happened before. And I read a lot about who has killed who and who has killed children. And it's whether it's just because of information technology or it's something which is new, and whether it's related to what we are facing in the world right now. As you said, time will tell. But there are quite a number of odd things happening.
Okay. So I think that's it for us. Again, bye everyone. Have a wonderful day. And in anticipation, happy holidays, Merry Christmas, Happy New Year. And we shall see you next year for 2022 Mrftt HIV STI. Be safe, everyone. Take care. Bye-bye.